Thank you for listening in to this very important topic. I am Dr. Major Vimal Raj. I'm a consultant cardiothoracic radiologist. I head the unit of cardiothoracic imaging in Narayana Hridayalaya, Bangalore. Today we're going to talk about chest CT and post-COVID fibrosis. This is a very important topic and has been labeled as the tsunami that is likely to follow the second wave of COVID which is hitting the country. My objectives for today's session are to tell you what is actually fibrosis when it comes to chest CT. The next important point comes is, what do we really call it? The changes that we see in post-COVID patients, is it fibrosis or should we be calling it something different? I'm also going to tell you who is likely to develop this fibrosis compared to all the patients that we see. Finally, I'm going to try and discuss about what does it actually mean to have this fibrosis. Does it have any clinical implications or not? We clinicians have become very used to seeing images like this, whereby we are seeing honeycombing at the lung bases. We are seeing some areas of reticulation, which are these linear opacities, which we have been calling as fibrosis. We are also used to seeing bronchi which are dilated, which we call as traction dilatation of bronchi. These all are very classical features of what we see in interstitial lung disease. Is this what we should be expecting in patients with COVID, or do we see something different? Now, if you look at this paper which spoke about looking at COVID-related lung changes, the two most common things that they found was traction dilatation of bronchi, very similar to what we are seeing in other interstitial lung disease, and also such parenchymal bands, which can be seen in other interstitial lung disease. It's also described to have multiple areas of honeycombing and also some focal areas of pleural thickening. Now these can be called as fibrosis. Traditionally, when we say fibrosis, we think about irreversible pulmonary damage. And some of these changes, for example, honeycombing, traction dilatation of bronchi, you would imagine these are irreversible. What about these bands? Do they settle? What about these areas of pleural thickening? Do they get resolved after some time? That is the main question that we all have to answer. Once we have seen these changes, it comes to a point of saying, what do we really call it? Now, if you look at what has been called as by Dr. Zarir Udwalia and Luca Ricciardelli and Dr. Call, that this is lung fibrosis post-COVID, and it is the tsunami wave which is likely to follow the earthquake, which is our second wave. On the other hand, some of the observers feel that we can't call all of these things as post-COVID fibrosis. They may be just post-COVID sequelae, maybe a scar tissue, but we should be very careful before we start calling these as post-COVID fibrosis. So, what do we really call it? It's easier to just call it post-COVID fibrosis and bundle all of this together, but it may not be very simple as that, because we have been giving some of these patients antifibrotic over the last year. Some of them have responded very well, but we do not necessarily know if they responded secondary to antifibrotics or they may have responded well anyway. One of the terminologies that people have used is to call it as a post-COVID scar tissue or post-COVID interstitial lung disease. Even some people have called it as a simple post-COVID sequelae rather than calling it fibrosis. The trick here comes with is the duration that you look at these patients. And over a period of time, what happens to these changes becomes very important. For example, if you see patients, if you start marking and doing tests after, let's say, 4 weeks of them discharging, you will find these changes. If you fast forward that and do it after 4 months, do you find these changes or not? And what happens to them after 6 months or maybe 12 years, which is where it becomes important that the timeline is defined. If lung parenchymal changes persist over 6 months or 12 months, perhaps then we can start calling these as post-COVID fibrosis. The next important question comes is, who is more likely to develop this? Well, based on logical reasoning and based on our experience, it is very clear that patients who have severe disease, either clinically severe or imaging-wise severe, these are likely to get fibrosis. One would imagine elderly patients who have other comorbidities would have had worse effect with COVID and are likely to have fibrosis developing in these patients, and patients who continue to remain symptomatic even after discharge may be having fibrosis. So this is our logical reasoning that we think are the patients who are vulnerable to have post-COVID fibrosis. As a standard, we would be relying on published literature to turn around and see who is likely to develop fibrosis. But there is significant publication bias because the major studies, there are not many, but the ones which are available have focused primarily on patients who've had severe COVID at the initial presentation. So these are the ones who we have followed up to see who develops fibrosis. We haven't looked at the ones who become well, who had very mild disease, or who were asymptomatic to begin with at all. So we have a heavily selected group of patients who we have follow-up for. Finally, if you look at our anecdotal experience, perhaps a lot of you may also have similar experience, is mild disease patients recover fully without any symptoms, and they are unlikely to have any fibrosis, and in the similar manner we do not image these patients. So this is the problem that we face. Patients who have mild disease, we expect them to recover. If they don't have symptoms, we are not imaging them. People who have severe disease, we expect them to have some kind of fibrosis and we are following them up. So now if we look at one point, which was patients who persist to have symptoms are likely to have fibrosis. So patients who do not have symptoms should not have fibrosis. This is a very small study which looked at about 6 patients who had a CT scan 4 months from their initial presentation. None of them had symptoms, but 5 out of 6 patients still had lung parenchymal changes, although they were completely asymptomatic, which tells us that absence of symptoms does not mean there may not be fibrosis. Other way of looking at it is people may have fibrosis and they may be absolutely fine. They may not have any symptoms at all. So the imaging finding may not be clinically significant in this group of patients. On the other hand, CT severity pattern of the disease. So let's go back and say people who've had severe disease are likely to retain fibrosis. People who've had milder disease are unlikely to have fibrosis. Let's look at some examples and see what you think about this. This is one such patient. At the time of presentation, what we can see are these typical findings that we are seeing, and peripheral areas, ground glass opacities. You would imagine that this is a moderate severity disease, and one would expect some residual changes in these patients at 4 months follow-up. So this is the 4-month follow-up, and you can see most of these things have resolved, and you're getting these band-like opacities. You're seeing some dilated bronchi, again subpleural bands, which by definition becomes fibrosis. So 4 months after, in a patient with moderate disease, developing some fibrosis. Let's look at a different case. This patient had just these 5-6 opacities. You can see the typical prominent vessel sign, ground glass opacity, and you can see some crazy paving in here. This looks mild disease, and one would expect this to have resolved without leaving any changes. However, in this patient, it seemed to have left much more scar tissue than one would expect. So it is not very easy to predict by the CT severity whether milder disease or moderate disease patients will have some residual changes left at 4 months interval. Let's look at another case. This is a case from our institute where you can see on day 6 of symptoms, we can see these patchy areas of opacities. You can see that this is relatively widespread. He had other foci also in the lung. And then when we follow him up nearly around 3 months, you can see everything is almost gone. Okay, a moderate disease completely resolved. So it is anecdotal evidence that mild disease resolves completely, but we are also seeing patients who have mild disease continue on to fibrosis but may remain asymptomatic. So you can see here moderate disease, one ends up in fibrosis, the other one does not end in fibrosis, mild disease still ends up in fibrosis. As of now, this is perhaps the largest study which has looked at CT appearances of patients who had severe COVID infections, around 114 patients over a group of 324 patients, and they have 6-month follow-up. What is very nice to see in this case was that 38% had complete resolution. 27% of patients, almost 1/3 of patients, had some degree of ground glass opacities and reticulation present at 6-month follow-up, while the more interested or alarming findings that we are having is another 35% of patients had fibrosis. So there is a fibrosis group, there is a non-fibrosis group, and there is an intermediate group which we are not quite sure, which may or may not go from one direction to the other, and perhaps we need more time in these patients to see what happens. When we looked at the fibrosis group, this is where it becomes important. What is the significance of this fibrosis? When we looked at the fibrosis group, what you're seeing are they were more than 50 years, most of them. They had ARDS as part of their presentation while they were hospitalized. The CT severity score was more than 18 in a majority of patients. CT severity score of 18 out of 25. Also, the diffusion capacity was abnormal in the fibrotic group. So this perhaps is the first evidence that we are starting to see which says that the lung parenchymal changes do have a clinical impact, do have a clinical correlation that these patients were having reduced diffusion capacity. Let's look at some of these cases. This is one interesting case, again from the paper, where you can see a patient who had emphysema, developed COVID, day 72, does reasonable recovery, still some ground glass, and by day 164 recovers, almost completely normal. Now this is amazing. You would imagine somebody who's got emphysema to end up having some fibrosis, to end up having some parenchymal bands or some degree of architectural distortion, but nothing. Everything looks fantastic in there. Now, this brings a very nice way of introducing two new terminologies which have been coined recently. One is called as a melting sign, melting sugar sign, and the other one is called as a tinted sign. This is a good example. This is a patient who had COVID. You can see diffuse areas of ground glass abnormalities on day 9. Day 46, something similar, getting a less denser, the ground glass, but the amount of involvement is pretty much same. If you do follow up, this is day 159, okay, nearing towards the 6 months interval. What you're seeing is that the ground glass has gone down, the density has gone down, but the degree of involvement, the extra area of involvement has expanded. You can see there is a larger area of expansion with this ground glass. This sign of reduced density but increased area of involvement is called as the tinted sign or the melting sugar sign. This is suspected to express the fact that the inflammation has gone down, but the alveoli have now started to expand. So, reducing inflammation, so the density goes down. Alveoli have started expanding, so the amount of ground glass or the extent of ground glass has increased. This is an example from our institute. You can see somebody who had day 8 extensive areas of ground glass opacities, significant COVID. By day 38, you're seeing a lot of resolution of these changes with some parenchymal band formation. And by day 143, we are nearly reaching about the 5th month. You can see some bands, some areas of ground glass, but not much of traction dilatation of bronchi. So this patient is almost towards recovery. So perhaps if we do a scan around 6 months, he is likely to resolve all the lung parenchymal changes. This is one case which I am extremely proud about and extremely surprising when you look at this. This was one of the cases which was with us for a long period of time. You can see this patient had extensive involvement. He had developed a loculated pneumothorax which we had drained over a period of time. Extensive involvement, pleural effusions, cardiac complications. There were lots of issues in this patient. So day 10, a month later, you can see the lung is really getting worse. You can see towards the bottom, again, it doesn't look like it is going to get better. But day 160, lung recovery is fantastic. You can see nearing the 6 months interval, you're seeing most of these changes have resolved. Definitely there is fibrosis. However, the degree of fibrosis is something we may not have predicted based on what we were seeing earlier in this case. So what does this all mean? Okay, one thing we are very, very clear that the fibrosis group has diffusion capacity which is reduced. The patients had dry cough as a symptoms, especially those who had more fibrosis in there. However, what happens to them in the long term? Does it all get better in a year's time, 2 years' time, or it gets worse? We really do not know. Multiple theories have been floated, one being some of these COVID antigens are basically triggering off a fibrosis, which is like an interstitial lung disease itself. Somebody who is prone to develop fibrosis gets accelerated, or it is a simple post-ARDS fibrosis, just like any other infection may give us fibrosis. One thing which I'm very, very confident when we look back at our cases is it is very difficult to predict patients who have mild to moderate disease whether they will end up having fibrosis or not. Patients who have severe disease are more than likely to develop fibrosis. That's something we are very clear. But people who have mild to moderate disease perhaps may also end up developing fibrosis, but there is no way on imaging at least for us to be able to tell these. The other side of the coin is a lot of asymptomatic patients, if they do get imaged, they do also show some of these fibrosis. So to summarize, fibrosis in CT in a post-COVID patient, you are looking for traction bronchiectasis, you're looking for parenchymal bands, you're looking for some pleural thickening. We are not sure whether this is going to be entirely irreversible or over a period of time it will get better. The patchy evidence that we have and evidence which is relating to only the severe diseases is limiting our experience on this factor. The ground truth may be different from one geography to the other geography, so only time will tell us about this. Finally, 1/3 of patients with severe COVID will develop fibrosis. Another 1/3 are likely to have some patches but not fibrosis, and another 1/3 are likely to recover completely well. This is severe fibrosis. However, the ones who have mild disease or moderate disease, it's more likely that maybe around 70 to 80% of these patients totally recover. We do not have the data about this group of patients. So more data is required, and I believe 6 months from discharge or 6 months from the primary CT might be a good cutoff before we start labeling any changes of COVID as fibrosis. Anything before this may not be the right way. It may be a bit premature because we are going to see a lot of these parenchymal bands which may not have any clinical significance. So hopefully I have given you enough of thought to process, and also I have shown you enough of images for you to understand what the post-COVID fibrosis appears, how it's going to be different from what we are seeing in interstitial lung disease, and what is it going to mean to us in future. Thank you very much.